thanks everybody for attending. We were just talking before this call, and I think everybody's calendars are pretty full with webinars these days, so we're really pleased that I've added one more to your week and have joined us this evening for a discussion on COVID-19 and its implications from policy to practice. My name is Emily, and I coordinate the Students Young Professionals Network of the CCGHR. The Students Young Professionals Network, for those of you that don't know, is a 200-member network of students young professionals, and essentially serves as a dynamic community of people across Canada interested in global health research as well as practice. We're pleased to bring you this webinar with a couple of different partners, the first being ThriveHire. Today we have Annalise on the call from ThriveHire, and I'll just pass it over quickly to Annalise for her to explain a little bit about ThriveHire.
Thanks so much, Emily, and thanks for also inviting us to be here today. My name is Annalise Mathers. I work as a research officer at ThriveHire. Hoping that lots of you have heard of us already, but basically ThriveHire aims to be a one-stop shop for people to get connected to opportunities in the global health sector. And so we have a few different ways of getting around that. So if you go on our website, we have organizational profiles of global health organizations that we work closely with. We also have a job board where people can apply to job postings. And then we also have a career kind of human resources blog where we post some top tips and interviews with other global health professionals. So if you haven't checked us out, please do. And thanks, Emily, for helping to set this up today.
Sure, yeah. So for those of you who haven't attended one of these webinars before, this webinar is actually part of a series that the CCGHR has been doing with ThriveHire for about the past nearly a year actually now. And it's the series is titled Launching a Career in Global Health, and it's a series that aims to provide information and insight on some of the less discussed challenges of finding a job in global health and just working in global health generally. We've had a couple of, I think, 5 or 6 webinars so far in this series covering topics like volunteering in global health, when the right time to go work internationally is in your global health career, and things like that. And really what we're trying to do is to hear from people about their global health or public health roles and to learn from them and hopefully gain some insight on what various jobs in global health look like. So this webinar today, we're going to be hearing from 4 different panelists about their role in global health as it relates to coronavirus and the response. So we're really pleased to have the 4 panelists talk today and contribute to this series. With that, I'll pass it over to Nina to get the discussion started.
Thanks, Emily. So my name's Nina. I'm a research coordinator at the Ottawa Hospital, and I'll be your moderator today. So before we get started, I do have a few housekeeping items. If you can go to the next slide, please, Liz. So please note that this webinar is being recorded, and the recording will be shared with all attendees. So do not share any personal information or sensitive documents in the chat box. Today's webinar will also include a question and answer period where you'll have the opportunity to ask questions in the chat box, or you can click the raise hand button in the bottom bar on Zoom. But by all means, you're more than welcome to submit questions throughout the presentation. It doesn't have to be during the Q&A, and we'll get them to them at the end of the webinar. And finally, if you're having any technical difficulties during the webinar, please write a message in the chat box to Lauren Murray, who is acting as our technical support today. So without further ado, I would like to introduce our 4 speakers. So today we have Lori Quinn, who is a patient service manager in the emergency department of the Vancouver General Hospital. We have Alexia Simoni, who is the head nurse of operations, also at the Vancouver General Hospital in the emergency department. We have Madeline Ashcroft, Regional Infection Prevention Control Specialist at Public Health Ontario. She's currently also serving as the Director of Standards and Guidelines within IPAC Canada. And finally, Dr. Smita Vakale, a respirologist at the Ottawa Hospital, as well as a researcher with the Ottawa Hospital Research Institute. So today's agenda includes having each panel speaker just briefly introducing themselves and giving you an overview of their role and responsibilities during the COVID-19 pandemic. From there, we'll move on to a panel discussion where we have a couple pre-made questions for our speakers. And finally, we'll open up to a question and answer period. So our first two speakers are Lori and Alexia. So I'll hand this off to you guys.
Hi. Sorry, just to make sure you guys can hear us. Yeah. We just want to say thank you for having us on this webinar. We're really honored. I know everybody across Canada has been working really hard to try and prevent the spread of COVID, and I think we're slowly winning. So we both work at the hospital in the emergency department here at Vancouver General Hospital. Can you switch to the next slide, please? So just a little summary of our hospital here in Vancouver, just for people that this is across Canada. We are the largest hospital in BC. We are a level 1 trauma center. We have I think all the specialties for the province, so we're a big referral center. We are not technically based in downtown Vancouver, although we're just right across the bridge, so about 5 minutes outside of the downtown core of Vancouver. We are an adult-only hospital, so we do see everyone that's 17 years and above. Everyone under that goes to Children's Hospital, which is probably just about 5 minutes away down the road. We see about 95,000 people a year. And in total, our hospital before pandemic had about 955 beds. And a lot of referrals from outside of the lower mainland, which is Vancouver and some suburbs around. About 40% of our cases come from other places from our province. Can you switch to the next slide for us, please?
My baby.
Can you switch to the next slide for us?
My baby. My baby. Hello, Manuel. I can't see you. Okay, now I can see you. Joanna,
It's split into 4 parts. We have a acute section, a psychiatric emergency section, a diagnostic area, and a treatment area, as well as triage. So pre-pandemic, we sort of would triage into these various areas, and then as the pandemic sort of progressed, we ended up switching all of our areas to manage isolation needs and screening processes. Can you switch to the next slide? We started off with very few isolation rooms, like many emergency departments. You never are completely prepared. I think when SARS happened in Toronto, Vancouver sort of developed a couple rooms that were really going to be key for us, but we didn't have capacity for a whole bunch of rooms. What happened is, as we started to get more information, started to continue to plan our capacity, we were able to create more isolation rooms and also more negative pressure rooms. And that was really related to our relationship with our facilities people and them being very creative and innovative to be able to provide that for us. Just the next one. So isolation screening is not a new skill for us. We've always done screening in our MERS. So this little cutout is what's actually on the front of our triage form. Yes, we still use paper. We're a little behind the times. We're not on a fully computerized system. So that's part of our infection control screen that we ask everyone that comes through the doors of the emergency department. So this isn't a new skill, but we did obviously have to adapt to the COVID crisis. So we did change some of our questions, and initially we targeted just people from the Wuhan province, and it kind of grew from there. But this is an example of how we were already screening, and we've just kind of built on that as a department. Can you go to the next screen, please? Next slide. So this is just really a progression of pandemic and how it sort of happened for us. And interestingly enough, I think with any sort of global health concerns, you get a lot of your information from social media. And so Twitter was a really huge thing for us. We started to hear about things that were happening in China in December around Christmas time. And with that, and knowing what our travel is like in Vancouver, we started to have a heightened awareness. And that's where we started to place posters in our waiting room, increasing awareness around screening. We started talking about isolation needs with our staff, and really related to what Alexia was saying with flu. But this just gave us more of a heightened awareness. We knew that something was happening. We weren't sure what the impact was going to be for us here in Canada, but we did have that heightened awareness. And I think like any emergency department, you're always sort of anticipating and preparing for, you know, the worst case scenario. And so I tell you behind the scenes, before it sort of emerged that we really needed to take action, the team here was really already starting to think, what would that look like in terms of how do we build PPE champions? How do we learn about donning and doffing so that we're experts, so that when this hits us, we're ready? And I think one of our things that we really channeled was that I would rather be known as someone who was over-prepared than someone who wasn't. And so we sort of kept that mantra, and that sort of was our driving factor in our capacity planning and process development and those types of things. So you can see that we made posters, we created champions, we started to think about protocols and how we can improve protocols, and really that mindset of that normal business has to change because this is not a normal time. And so that really brought us together as a team. I think the other thing to mention is that we always have had a good relationship with our infection control practitioners. It is a routine practice for the infection control nurse to do a round in the emergency department and check in with the head nurse and the charge nurse in the morning. So we already had that relationship with our infection control team. And so it was just really easy to build on that because we know them by name. They're in our phones. We can text them. We obviously have very close relationships with them during the flu season. So this is just something we've already just built on a relationship that already existed. Can we go to the next slide? So we all know March 11th, it was declared a pandemic. This was actually a picture that was taken by our emergency nurses, and it was posted on Reddit, on Instagram, and a bunch of other kind of social media outlets, just about the importance of staying home. We were pretty proud of this actually. And I think March 11th was the day it was declared. But our senior leadership at Coastal Health we'd already been having conversations. There was already a virtual emergency operations center up and going, and they were starting to ramp up. And so March 11th, it was declared, but I really believe that we were able to be much farther ahead of the game. And so that really changed things for our department and how we were functioning, decreased some of the anxiety because we were already having these conversations. Go to the next one. So these are just some major changes that we made in our department. So we initiated this pivot nurse role. So the pivot nurse is a triage trained nurse, and they're actually sitting at the doors that open to the ambulance space. So anybody that literally walks in off the street is immediately stopped by this pivot nurse and screened. We have lines on the ground. They're separated, so we're over 6 feet apart from them. There's a hand sanitizer station. And this is how we did our first changes. How can we screen and change our screening process for patients so that we knew that we had to keep one area of our department dirty and try and keep one area of our department clean and put the appropriate places in both places. So we revamped the entire triage process. We had a fast screening where we were going to place patients. I mean, obviously, being in an emergency department and having almost every single specialty in our hospital, I think we might have all the specialties in our hospital except for anything to deal with pediatrics. We also have a little bit of all sorts of different types of equipment. So our department is pretty cluttered on a regular basis. So that was a big process of decluttering and moving equipment around so that it wouldn't get contaminated with the virus and just contaminated in general. So that was a huge kind of logistical move of a lot of equipment. And I think just to speak to that decluttering, you move from a position where you want to create efficiency. So you have everything in the room so that you can be fast and efficient when you're seeing emergency patients. And this was taking on a whole different mindset where you wanted to reduce contamination, and exposure and safety became more important than efficiency. Efficiency sort of had to come through your process in terms of how do you get patients in the right room quickly, how do you get them seen and either discharged or moved on to the admitting inpatient unit. So efficiencies had to look a lot different, and decluttering was something that was moving away from our previous mindset. It was an interesting process, that's for sure. It was hard. We did have this room we called the pandemic room, and it could house 3 stretchers at triage, and it actually has like very good negative pressure. And we had used it previously when the swine flu happened some years ago. But we started this kind of fast screen process where if you were a well-looking person that potentially could have COVID, that we would actually not even bring you in our department, and we would just immediately screen you into this pandemic room where you would sit, get swabbed, see the doctor, and go home. And so we never actually had them come in the department to potentially contaminate other people, and they would just stop just triage. We mentioned how we really didn't have a lot of proper negative pressure rooms. So with the help of our facility maintenance people, we converted, I think, 5 more negative pressure rooms. And then we actually relocated our treatment area and made that a clean unit. So we actually took over the inpatient psych unit who got reallocated, they got moved to another building. And so we actually had to move an entire clean unit over there, reallocate the rooms, obviously work with the space that has magnetically locked doors, the no-flow water toilets, but this is an inpatient acute psychiatric unit. And we've been able to convert that into a clean unit that we can see patients and get them in and out of there safely without the potential of being contaminated. We also then took our trauma bay, which is a 3-bed unit, and it does have doors, so it is an enclosed space. And we turned that entire room into a negative pressure room because we know that there's still going to be traumas and other things that occur during this pandemic, and we need to prepare for them. We are a level 1 trauma center. We do have a responsibility to still be able to adequately look after trauma patients. But I know that we knew we were going to come to a point where you're just assuming everybody's positive, and how do we proceed with that? I think we have a picture on the next slide to show how we converted that space. And then some of our ongoing work is just the development of protocols and processes, guidelines in terms of documents to support staff, virtual meetings, town halls, wellness meetings, all those things that you put in place to support your staff so they feel confident, they feel that there's people are watching out for them, all those kinds of things. And really it was around not only supporting them, but trying to manage that concern and that anxiety that I think everyone felt across the globe, not sure what exactly we were dealing with. And so these were some of the things that as we progressed, we were able to develop and share with our staff. And I mean, at the very beginning of all of this, things, processes, screenings, all those kinds of things, they were changing every 4 hours, every 6 hours, and our staff were just getting so overloaded. And so giving information, sharing that really helped reduce that stress so that they could really be confident and do the work that they do really well, which is feeding care for patients. You can go to the next. Yeah, so this is just some of the work in terms of what our facilities did, how we moved things, just all the work that it requires, which is for about 3 weeks, our whole emergency department was completely transformed in terms of spaces, where we're housing equipment, how we're housing equipment, not to say protocols and processes as well. Can you go to the next slide? Yeah. So these are some of our key components, and they're really just generalization. So communication is central. It's just like patients want knowledge, so do staff when they're dealing with something new. So we really do huddles, every update was given, but you want to find it in a way that is manageable and not overwhelming people. And so We really worked at trying to develop some consistent days of messaging and then one-on-one or face-to-face conversations. Education, yeah, I mean, they're not on this webinar with us, but the other key part of like how we've been able to succeed with this is our education team. So that's Claire Gurney and Julie Lockington, along with two other head nurses that aren't here, Jonathan Ho and Scott Mayer, and obviously it's Lori. So we really work together. Our education team puts out updates every twice a week. On top of our normal weekly email that we do send out. They've been on the floor, they've been, finding people to be champions of Johnny and Dauphin. Like, this has been a lot of work behind the scenes for our team, which we do happily to make sure that our colleagues are safe and our staff are safe and that we can help kind of flatten this curve. But education has been so crucial in this. Yeah. And I think the last component that we've mentioned sort of throughout is just that collaboration and working with your team. So from facilities right up to your intensive care anesthesia, how those people come together, collaborate, all with a common goal. And when you take a bunch of different departments and units and you have them all working in their own capacity and then you try and bring them together, there's always a little bit of storming. And I will say that was also a challenge, but has come together so nicely with just consistent times to connect, huddles, those types of things. And that's been really, really important for us in our success or ability to manage. And that's just a picture of some of our staff that are, ready for the next challenge, ready to help patients and help this fight against COVID.
Thank you, Lori. Thank you, Alexia, for sharing. I know BC has demonstrated some early success in flattening the curve and definitely gives the rest of Canada some hope. Our next speaker is Madeline Ashcroft, who will be giving us her perspective from the infection control perspective.
Sorry, I had to unmute. Thanks so much for inviting us at IPAC Canada to participate in this webinar. I have the privilege of being, as was mentioned, the Director of Standards and Guidelines for IPAC Canada, and our head office is actually in Winnipeg, but I work for Public Health Ontario in Toronto and cover a very large region with three others colleagues who are IPAC specialists, which is currently aligned with health units. So Peel, Simcoe, Muskoka, Toronto, trying to think of all the other ones, York, and as far over as the Peterborough and Durham region, and a little bit of Haliburton, Kawarthas, Pine Ridge as well. So big area, lots of things going on. And I just wanted to share some of the things that I've been doing during this outbreak and try to reflect how that might be somewhat different or similar to what's going on, for example, in Vancouver with their IPAC leads in your setting. So if you could move to the next slide, please. So, it's already there. So my role in my normal job is to answer questions. And again, that is also part of my role during COVID, as well as keeping current with science and government information and directives. And certainly here in Ontario, these are changing very rapidly. So it is at times very challenging. You're talking about something and it changed overnight and there's a new directive and a new requirement. And we also support public health and healthcare professionals in a variety of different settings with best practices. So we provide scientific and technical advice, and that's really our normal role. And that has expanded in COVID. So this is our Public Health Ontario website, and I hope that those of you, particularly in Ontario, will make good use of this. But that is just the main site, and then if you click on coronavirus, you get to all kinds of interesting things. And they are sort of in order of who clicked the most on it, so it'll come to the top. In the sidebar there, where it says health topics, you can also click on that and go straight to IPAC, but anything to do with COVID is also right there. So we've got loads of resources, we've got lots of scientists working on different things. What is airborne versus aerosol? what is an aerosol generating medical procedure, is a cough or sneeze such a thing, and so on, as well as what we know so far, which is a synopsis of different articles that are in the literature that are giving us information, for example, about the virus or different aspects of its transmission and so on. So great site, and it has links to all the other ones as well, like World Health and Public Health Agency of Canada and so on. Next slide, please. So this is the kind of thing I've been doing for COVID response, and compared to Laurie and Alexia, I've only got 3 slides, so I won't be taking up a lot of time, but hopefully there'll be questions and answers as well. So what I've been doing is providing IPAC input into responses and evidence briefs. So I was asked to, a colleague of mine and myself, we were asked to stay on site while others were working from home, and then we were moved to the Mars building, which is where the labs are and so on in downtown Toronto, and we were working out of there. And we would have things flipped to us to say, you know, do some searches and make recommendations. And some of the things we were able to provide advice, well, me personally, what I worked on was PPE with confirmed and suspect cases, exposed cases, non-exposed negative patients and residents and so on. For example, particularly as the Bob Cajun outbreak was within our area, and so many staff were exposed right away before they even knew. So we had to come up with this concept of working isolation, how staff could work even though they'd been exposed if they wore PPE and they isolated themselves in their home setting. Since then, I've noticed that some of the homes I've been to that they are actually putting their staff up in hotel rooms so they can isolate, so they're not having to be with their families because there may be just one washroom with little children and so on. And so I think that's also helped. But this is a concept we in infection control probably wouldn't have thought of before. We would say, oh, you're exposed, you better stay home, or until you're, you know, test negative and so on. But even now, if you test positive, you may be able to work if you have no symptoms and you wear the PPE properly and in consultation with your facility and public health. Another thing that I was able to advise on is infection prevention and control practices for workers in corrections, transit, and communal settings. For example, non-healthcare workers in retirement homes, group homes, and supportive housing and those kind of settings. So early on, there really wasn't anything from Public Health Agency of Canada or even CDC or European advice. A week after I sent that information forward, other information appeared on, you know, from those sources, and I did say, shall I update that? And I was told, no, we just needed what we got from you at the time, and we don't need you to keep updating, which was great, because they wanted an evidence brief with like 2 hours, and I'd never actually done an evidence brief with all the references and everything, all on my own. So that was a good opportunity for learning. Also, as I mentioned, I think before, about airborne versus aerosol. We have a lot of questions about that, and you can see if you look that across the country there are different examples of what counts as an aerosol generating medical procedure, and then how long does it take to clear the room of any aerosols. And we believe it is not the same as it takes to clear the room of airborne bacteria or viruses, for example, chickenpox, measles, or TB. And in the past, we've always gone with that TB document that shows how many minutes you'll need based on the air changes in the room. That's also in our PIDAC, routine practices and additional precautions document, Appendix D, page 62. I know it by heart now, I've quoted it so often, but that is not the same as aerosol clearance, which is more rapid, thank goodness. Questions also about high flow oxygen, and which of those might be an aerosol generating procedure. And conservation of PPE, another thing we never thought we would see, never telling people to wear your mask when you come out of the room and continue wearing it all day, and or at least till your next break. And, you know, now we're saying things about, you know, store them for potential reprocessing. People are asking about reprocessing of alcohol-based hand rub containers. In some places they've run out of those. These are all things we always said never to do. But I do think that, and some of my colleagues are terribly frustrated about this, but I think that, to me, this is what we should be doing in infection control. We should be saying, if in a perfect world, if you have all the things, this is what you should do. If you do not have these things, how can you reduce the risk in your setting to as low as possible, given what you have, and come up with innovative ways to reduce that risk? So that's something we are doing quite a bit of these days. And finally, this past week, I just started doing IPAC assessments. So we've finally been able to go on site, and I have gone to some of the long-term care homes that are in our area that are in outbreak. Some of them have had terrible experiences, many cases, many deaths. Some of them have put great things into place already, and others have a way to go. And one of the things we're offering virtual visits, but it seems to me that most people want somebody to come on site. So I am going in, as is one of my colleagues. We have offered to do this. I'm quite confident myself that I'll be fine, because I did go to Sierra Leone for Ebola relief with World Health Organization for 3 months, and I didn't get it out in the jungle there, because I like to think my practices are good. So I feel, you know, that I can protect myself and others suitably in these environments. But sometimes I go in and find everyone is in all kinds of over-the-top PPE in these homes. The minute they walk in the door, you know, the gowns, gloves, double masks, eye protection, face shields, you name it, and they're wearing them the whole day. And as we all know, gloves need to be taken off and hands cleaned after you've cared for somebody, even sometimes on the same patient or resident. So trying to help them get over that is a big challenge, and trying to help them feel safe in the workplace, especially when their union is telling them they have to demand certain things, and especially when some of their colleagues have died. So it's a scary time for people, and I think that part of our job is to build that confidence again. So I have a picture at the bottom there, and that's outside Edenville, which is one of the long-term care homes that has had a lot of cases and a lot of deaths. And I was actually pleasantly surprised when I went in there. Yes, everybody was working double shifts and more, and the director and administrator were you know, providing care on the floor, but the morale was good, and the residents' morale was good, and more help is coming in every day. And these are just some lovely signs that the community has put outside for their residents who are, you know, basically isolated inside the building. And also supporting the caregivers there. So it was you know, put a happier slant on a very sad and challenging time. And I think that's it for me for the slides. Thank you.
Thank you, Madeline, for sharing. Our next speaker is Dr. Smita Vakale, who's a respirologist as well as a scientist at the Ottawa Hospital.
So thank you, everybody, and thank you for inviting, and thank you for organizing this. It's very informative, and I think much needed at the time. So thank you, Lori, Alexia, and Madeleine for covering the nitty-gritty parts of the stuff. I thought I would cover some stuff from the subspecialist point of view, what happens at the hospital level, little bit, so that fill in those gaps. But of course, people are free to ask any questions, and we'll keep enough time for that. As Nina said, I work at the Ottawa Hospital. I'm a respirologist, but also do a lot of research, and our research is involved with people who are vulnerable, like marginalized, homeless, and at risk for homelessness, a lot of indigenous population downtown, and those who are aspiring global health, young population in the crowd. I would like to say that, you know, global health, you don't have to have wings to find the global health. Global health is right under your noses, right where you live if you look. I live in Ottawa, the capital city, and a few blocks from the Parliament Hill. We have the dire poverty and homelessness, and that is my population of interest, and we work in partnership with them. So I would like to share light on both of these things. Can you get me the next slide? So from the clinical perspective, you know, as a subspecialty, like at the hospital level, like other people said, we turned off all our regular kind of a clinical practice, what it was, like the hospital canceled all their regular scheduled surgeries. We canceled all our regular scheduled clinics, all the procedures like pulmonary function test, which is one of the aerosol generating procedure, and turned our clinics all to either phone or telehealth. And that again brings its own kind of limitations, because you don't have the patient in front of us, and as a subspecialty our clinics are booked like months in advance, and these people are waiting to see for months, and then suddenly, you know, your clinic is cancelled. So we didn't cancel anybody's clinic, but we couldn't bring anybody in, so we just are making do on phone whatever we can, and that's of course is limiting, especially from respirology point of view. I also run a severe asthma clinic, and you cannot you know, auscultate, you cannot see how they are doing in person, and that's very, very limiting. We, as I said, we do not have pulmonary function tests running. We are doing absolutely emergency procedures because it is one of the aerosol generating procedure, so we canceled all our non-urgent regular PFTs. So that is again another limiting factor for us, because all my patients or asthma, COPD, bronchiectasis, whatever, they first go to pulmonary function test and then come to me. And that's been our routine, because that's how we assess patients. Similarly, radiological tests, our regular CT, regular x-rays are not there. So we are just doing emergency ones. For the hospital point of view, again, like all you said, at the Vancouver site and other places, we also have created kind of a restricted entry places where people are screened, and separate entrance for the staff, separate entrance for the patients. As soon as the lockdown started, there was no visitor policy, like all over the hospital, like literally like no visitors. And suddenly we realized like we sometimes need people to get consent, or, you know, if you're doing some research study or for procedures. And then we started allowing some people for that. Of course, end of life care is very crucial, and in those circumstances we started then allowing some visitors. So but still we continuing on the restricted visitor policy at the hospital. Again, Madeline talked about the conservation of PPE, and that's been a challenge even with us, and we are trying to work with what we have. And even before we started, we had like N95, some numbers we did not have, and so it's an ongoing challenge for the whole country, as you know, and we are trying to make do what we have in the best, and try to minimize everybody's infection rate. You want to get me next slide, Nina? So my other life, my other hat is the community-based participatory research. As I said, we do research in partnership with people, so people who are homeless or marginalized, at risk for homelessness. And we have a brick and mortar center, which is the Bridge Engagement Center. People have named it as bridging the gap between us and them. As you know, there is a lot of stigma and stereotype. And we design projects in partnership with them, like people from the community are trained as community peer researchers, and they do the research, they do the recruitment, they do the implementation of the protocol that they have helped create, the questionnaires that they have helped generate, and they help us in analysis. They are our co-speakers, they are co-presenters, they are on our grants. Like we have involvement of patient from like literally from A to Z throughout the process. So that being said, we do all our projects downtown at the Bridge Engagement Center, but with the COVID lockdown, we had to again stop that. And that you can imagine what could be the devastating effect on this population for some of the people that place that they come or socialize or just come and sit and have a coffee. And a lot of these people don't even have phone or any other place to go to. So some of the people we are keeping in touch with through our community peer researchers by phone and just making sure they are okay. But there are a lot of people in our projects who do not have any phone, and they would just come in and walk in, and they know we are open. So those people, I don't know, I hope they are doing okay, but we have no way of knowing because our door is closed. So we hope our project starts soon and we can then engage in all other things what we do. We work on their education or housing or employment and other social support, and it's kind of a hub for them. And this is all through research project, and we measure everything what we do because we believe in measuring and making sure that whatever we are doing making a difference or not making a difference, and we can demonstrate that through academic rigor. You want to get me next slide, Nina? So as a part, we did the earlier picture was from a Run for a Reason. We did a run race and people with the people on the downtown. And what we are trying to do is get people involved in different activities and whatever they like to get involved in, and try to build bridges through those different activities. Now, before even this pandemic, the social and health inequities, as you can imagine, were tremendous when you come to this population. As I was saying, you don't have to go somewhere flying to find global health. It's right there under our noses. So these social and health inequities are so humongous. I will tell you one example from our previous project, that about 80% people had said yes to food insecurity. This is well before the pandemic. So you can imagine what must be the plight of all those people with this kind of a lockdown where they cannot go places where they used to go. A lot of places are closed or modified hours, and their insecurity is even exacerbated by this. As we know from some research down south in US, that African Americans were found to be more severely affected by COVID-19, and the death rate was higher. So also we know in Canada, during previous outbreaks, we have seen Indigenous people were more affected, as you would expect. Unfortunately, all our projects at the Bridge has more than quarter people Indigenous without doing any extra effort. As we know, in Canada, there are only 4% Indigenous people. And in downtown, when we talk about the inner city poor people, homeless, marginalized, more than 25% are Indigenous. That's very sad commentary on Canada right there. It's a big global health issue. So affecting, these kind of pandemics, affecting them disproportionately is very, expected. So we have seen that during previous outbreaks that they were more affected, and it was not their social or demographic position, but it just the overall, so many complex social determinants of health are involved, and they are still living at the margin of the society. It doesn't matter they are in the Indigenous reserve or they are in the city, they are still living at the margin of the society. And this inequity, we got to be addressing more, in a honest way, I would say. It should not take a pandemic for us to talk about these inequities, because they exist pre-pandemic, and we urgently need to deal with this. Next slide, you have.
Well, thank you, Dr. Barkali, for sharing. You definitely bring up some very valid points. Oftentimes pandemics are perceived as equal opportunity events, but as we've clearly seen from previous outbreaks and current US data, that's not necessarily the case. So just as a reminder, if you have any particular questions for the panel or any particular speaker, feel free to write it down in the chat box. Our first question actually goes out to Lori. What prepared you for this pandemic experience? In particular, what skills or lessons are you leaning on during this great period of uncertainty?
Good question. Thanks for asking. I was very fortunate to be part of the team that prepared for the Olympics and helped develop and implement and build essentially the polyclinic up in Whistler, which was very exciting, but sort of out of my scope of practice in terms of logistics and tents and all those kinds of things. But I never thought I would use those skills again, but in capacity planning here, and looking at negative pressure rooms and all those kinds of things, working with logistics teams, that experience really helped me. The other piece was, how do you bring teams together and get them practicing? People who don't know each other, because in the games we had people from across Canada come, all types of medical people, and having to get them together quickly so that they could function at a high level. And so that same sort of planning happened during this time as well. So how do we bring teams together in areas where they're not used to practicing? So like negative pressure rooms, tight confinements, decluttered rooms where you don't have everything at your hands. So how do we do that? And I think I leaned heavily on the Olympics, my experience with the games there this time. I never thought I would, but yeah.
Madeline, do you have anything to add? I know you briefly mentioned you had some experience working with the WHO in the previous Ebola outbreak. Oh, you're unmuted again.
I'm trying to keep quiet. Sorry, but the main question you were asking, sorry, could you go back to that, because it wasn't one.
What prepared you for this pandemic experience? Any previous lessons or skills?
Right, yes. Well, you know, SARS in Toronto, right? I went being a critical care nurse really most of my life, but also done some home care and a variety of things. And so I went into infection control a few years before SARS hit in Toronto, and I was in geographically the epicenter of it. I was in Scarborough, but you know, I was in a hospital that didn't actually have any cases, but we had everybody in quarantine because they had been in hospitals with cases, and anybody who got a little sniffle was, oh, they must be positive. So having been through that, we thought we were well prepared in Ontario. Yes, we've been through SARS, we know what we're doing. And this, of course, has shown us that despite the fact we did have some things in place, for example, here in Ontario, Regional Infection Control Networks, I was one of the original network coordinators for that. Now we've reorganized into 5 larger regions, but also Public Health Ontario, or the Ontario Agency for Health Protection Promotion, PIDAC, all these other things came out of SARS. So I think we thought we were well positioned to deal with this, and I think at first maybe we were, but this pandemic has shown us that you can never be too prepared. And also the things about, you know, PPE and so on, we had prepared influenza pandemic plans, and we had dealt with H1N1, which was, you know, not all that massive a pandemic, given that a lot of people seem to have some kind of previous immunity to it, especially the elderly. So those elderly who are usually the ones who really fall ill in these kind of things didn't fall ill so much in that. So that maybe gives a little practice, but not to the same degree as this. I actually must say I did volunteer to go to Africa because I was kind of frustrated here to see us all using all our PPE up. We never even had a case in the country of Ebola. So I thought I really want to go fight the real thing. But even that was a very different thing. So I think this is a good opportunity to connect and learn and constantly be open to the things that continue to innovations and new things we're learning, and the fact that we don't know it all and we do have to learn and grow continually.
Thank you. Our next question is for Dr. Bacale. So gender equity has been a huge topic of discussion during this pandemic. In Canada, 7 out of the 14 provincial and national public health officials are actually women, which is reflected in our panel today. So throughout this pandemic, has there been been any female leaders or healthcare professionals that are currently inspiring you?
I mean, as you have noted, and thank you for the question, though, it's a very important question. And as we have seen this gender equity and issues come up, even, I don't know if you remember the economic collapse and the housing bubble and the banking collapse occurred in more so south of us than with us. And that also showed that people in Iceland, I don't know, there was a very good documentary I saw that people, those institutions where there were women leaders, those did very well in the banking sector, you know. So similar to that, we are seeing now in this kind of a global event, a lot of women leaders around the world are shining, I would say, shining examples. And that maybe because women are smarter, but also there are some men leaders, I wouldn't take the names of them, but are showing really the depth of the ignorance. And the discrepancy is like too big, but I wouldn't go there. But just fun aside, I mean, you know, right, starting from Vancouver, there, Bonnie, your leader, is like really had kept her calm and grabbed the, I think, trust of the general population by her demeanor and, you know, giving some trustworthy information that they could believe. And that is very, very important. I think trust in the leader or the person, you know, showing that kind of status, even at the national level. You know, Dr. Teresa Tam is doing a wonderful job in terms of giving information and keeping us all doing very good job. And the international scheme, the New Zealand leader is, you know, also very impressive. And all these are very, I mean, I think I always say that, like, you know, there is always something to be taken from each of them. And all these are very good examples, actually, in today's context where we have seen women leaders shining on the world stage.
Thank you. One of our participants even wrote, "Women leaders are rock stars." So on a related note, this one is for Alexia. So how has your health institution encouraged gender equity during a pandemic? I know a lot of reports are generally saying that men right now are more disproportionately impacted, but just what are your thoughts on that and your current health institution in terms of gender equity?
I mean, I'm fortunate to work in a hospital where the majority of people that run the hospital, CEO, COO, executive directors, and director of the emergency and the ICU are all women. So, I mean, we're not changing anything. We just happen to work in a health authority that is very, has a lot of very strong women leaders. And this is what it was before the pandemic. And they've been calm and well-spoken. And they've led us through this pandemic, all the way from our CEO down to my manager sitting right beside me here. So I think they've not really done anything specific to like help with gender inequity, because I think that we're pretty lucky that we work in a health authority where there's quite a few women in very, you know, positions of power and able to help with change and get us and see us through this. As I mentioned, like our CEO had opened a virtual emergency operations center at the very beginning, and they started working on this right from the start. And we've had a lot of women on the emergency operation. And this is kind of the normal process for a hospital if we were to declare a disaster. A lot of people that kind of sit in these important roles are women, fortunately. So I just feel kind of really lucky to work in this health authority where we have a lot of really strong women leaders to look up to.
Thank you. Madeline also mentioned that Bonnie Henry in the Toronto area during SARS was also a wonderful female leader as well. Dr. Bacale, I know you said you had something to touch on in terms of men being disproportionately affected.
Yeah, no, we've seen the current pandemic is affecting different age groups differently, like elderly people are more affected, and also more mortality. But also when you see the male-female divide, there are more proportion of males being affected, even the statistics from China, statistics from Italy. And you know, there could be some reasons for that, like immunologically, there are differences in men and women. Like as you know, like even right from the get-go, if there are adverse situations and the male babies can't survive much of that, but the female babies do, and that is there. But also the immunological milieu of male and female is different little bit, that females, you know, kind of stride through a lot of different things more strongly than males. And maybe that's why more females do have also a lot of immunological diseases also, on the other hand, like, you know, lupus and those kind of entities. So we don't know, because of those kind of inherent immunological differences, like how we fight the infections, and that's why maybe men are more affected by the current COVID. It's the speculation.
Oh, thank you. So we do have time for one more question. I think I'm just going to open it up to the panel. What federal and provincial policies have you felt have been successful, and what can be improved on? Is there someone that wants to start?
We'll jump in.
Okay.
One of the biggest challenges out west here is that the screening criteria has really changed a lot, which unfortunately has led to some inconsistencies in the testing. And just even in the last week, they've changed it again, and they've left it to the discretion of the doctors, which has basically has kind of overwhelmed our lab testing facilities, because a lot of surgeons are screening people preoperatively who are completely asymptomatic and have no real risk of being COVID positive. So, I mean, I wish, in retrospect, and I know it's hard because things were unknown, but a lot of the screening criteria was quite vague for us. So it was really up to the practitioner's discretion whether or not they think they would screen or not. So it was kind of hard to enforce that and make sure that we were swabbing appropriately, because we were for quite some time at a risk for running out of swabs. And so it was really hard. It wasn't like we had an unlimited amount. We were literally running out maybe daily, where we were on the last like 5 swabs, and then miraculously another box would show up, and we'd have to hide most of the swabs so that we'd have more to be able to test people who really need to be tested. So it kind of just put excess pressure, I think, on us and our stores people, and a lot of pressure on the lab to kind of produce results, and potentially for a lot of swabs that should have maybe never been taken.
Could I jump in on that too for swabbing?
Yeah, so go ahead.
Yeah, we've been, you know, we were short of swabs and testing, and I work for Public Health Ontario. It's a Public Health Ontario labs. I do, you know, initially we're doing all the testing, and now of course there are other labs, hospital labs, private labs doing them too. But everybody's in it together. Now we have much more capacity, which is fabulous. So now we are actually, the past week or so, testing every single resident in long-term care and every single healthcare worker in long-term care. We've done a blitz of the hospitals. But what we're finding is so many asymptomatic positive people. And I'd heard about this amongst children and young, healthy people. I didn't expect to see it amongst the elderly population. And so I think that is really, if we'd been able to do this earlier, we would have had much more reliable numbers. You know, my sister is in England. She's telling me they're only swabbing people who, as we were doing at one point, who are going into the hospital because they're sick enough to be admitted, or that have contacts of positive people. And she's saying that also their death rates, they have, I think, 20,000 deaths, but it's in hospital. What about the deaths in long-term care? What about the deaths in home settings and so on in the UK? So they're not capturing that. So the different ways swabs are being done internationally, but as well across Canada, really impacts the number of reported cases, because these are cases that have been confirmed versus, death rates and so on. The rates, it impacts the rates, right? Obviously you can't really hide the deaths, but if you don't know the numbers of true positives, it's going to give you artificially high death rates as well. So I think the more swabs we can do, the better. I know at the beginning in the long-term care homes, people were saying, oh, we'll just do, 4 swabs like we do for a flu outbreak. And I would say, please, no, this is not a flu outbreak. This is an international pandemic. We need to be able to do the tests. So I'm pleased that we're able to do them now. I'm sorry we weren't able to do them earlier. I don't know if anybody else wants to talk about swabs, but another thing that a policy that I think was long overdue here that they did well in BC was telling staff to dedicate themselves to one workplace. And certainly we found in the long-term care homes here that people work in a variety of different places, a variety of part-time jobs. And we think that was a really contributing factor to the spread amongst and within long-term care homes. So, of course, now people are dedicating themselves to a home that's not an outbreak if they can. So the homes and outbreaks have been more impacted. But now we are actually getting the Army in some of these homes as well. And some wonderful nurse volunteers who've retired or other people who want to make a difference have come forward too, so that's helping.
So unfortunately, that's all the time we have today. I just want to thank everyone for attending, especially to all of our speakers. So we will be sharing the recording and resources after the webinar, but feel free to reach out to us on social media or on our emails listed on the next slide if you have any other questions or further discussion. And stay tuned for our next webinar within this series. Registration details will be released shortly. So have a good night, everyone. Stay healthy, stay safe, and thank you so much.